All right, this is a class 1 constricted aligner case. Let's get into it and have some fun. So Candace came to us. She didn't want braces. She wanted all the attributes of what we present with arch development with our Damon Ultimate cases, and we, had a solution for her. So shifting gears a little bit, I know that we do a ton of stuff with braces, but we also have a very busy aligner practice, and we want to kind of showcase some of those cases as well. So let's go through this. So a little bit different protocol. I want to kind of give you guys an idea of how we think about aligner cases. Again, we do the same thing. We break our aligner cases up into 3 phases so that we can have some structure in our clinics. So whether it's braces or aligners, we go through 3 rounds so that we can really kind of compartmentalize the objectives and the goals. So when we're looking at these rounds, the first thing starts with how we think, diagnose, how we plan, and how we treat. So let's first start about this. We've got this comprehensive aesthetic diagnosis in this case. Nothing crazy, right? She's really kind of narrow in the upper arch. She's crowded. She's got some overbite issues, some tooth enamel issues, but nothing crazy. The biggest part about this case is that we need good arch development, arch width, lower uprighting, and resolution of crowding without flaring the teeth. When we go ahead and we look at her x-rays, there's nothing too crazy about it. So when we are looking at her primary case submission, it's very important for us to communicate with our techs. When you're doing braces, it's a little bit different because, you're doing the planning, you're doing all of the observation and kind of looking at it as it comes in. But if you really want to be efficient with aligners, you have to be very specific to the techs on what you want. So we break all of ours up into the 3 planes of space. So transverse upper, transverse lower. Her objectives were to basically expand and then add buccal root torque as we expand. Vertical, we wanted to maintain the vertical position of the central incisors and then tell our techs what our specific artistic look we want. 0.5 millimeters off the table on the laterals and canine the same the central. And we also want to go ahead and level the curve of SPE with intruding the anterior teeth. Sagittally, we want to maintain the class 1 position. So now we've given our tech the X, Y, and Z axis of the teeth. Now we go into the aesthetic issues. Macro, advanced maxillary incisors slightly for improved lip support, mini aesthetics, improved buccal corridors with expansion, and we want to maintain the smile arc. And then for the micro aesthetics, this is where we want to talk about small things like interproximal reshaping of the upper anterior teeth and adding some labial root torque on the upper laterals so that we get really nice upright teeth. Again, we'll add some specifics. The tech doesn't care about this, but this is just so the doctors can be all on the same page. Once that gets submitted, we're going to get our first case workup back. And the most important part about our 3-phase approach to aligners, which we talk about in our courses, is phase 1 is all about major movements. Okay, this is where we want to do all of our development and alignment. We want to make sure that we resolve the rotations and crowding. Maxillary transverse is most important. Transverse first. We have to dictate the vertical of the anterior and then start leveling the lower. If we do have a significant AP issue, we'll start attacking the AP problem in phase 1. So before and after, you can see that we got some really beautiful arch development. Teeth look great, occlusion's nice. So, we definitely hit the mark on this case, and I'll show you how clean it was. Treatment time was about 14 months. So if we look at her first phase, what did we want to accomplish? And this is where the goal comes in. So if we look at this setup, we have transverse first, right? As we're expanding the posterior, we're uprighting the lowers, we're intruding lower incisors, and we're maintaining the torque or the facial inclination of the posterior teeth. If we look at this from the side, you can see that we want to maintain good buccal occlusion. The attachment design, which we go over in the course, is very simple. We use a lot of beveled attachments. I know that there's some controversy over which side you push from, but being a purist in physics, I like a flat surface with a line of action going through that. 90 degree works really, really well. So we're always going to bevel the attachment in the direction of tooth movement. Okay. So you can see on the top, we have these kind of 45 degree attachments because I'm trying to rotate and extrude. That would be on that maxillary left canine. Here's where you really see the beauty of the arch development. You can see that we're trying to develop and maintain beautiful arch form. Obviously, tooth number 13 is rotated 180 degrees. We're going to maintain that. There's no reason to try to rotate that back around. It probably wouldn't work, and more importantly, it would cause some significant issues and time delays. So we're going to just leave that tooth. We express that to the patient. Lower incisors, transverse first. We want to upright or buccally tip the lower bicuspid region, rotate the molars so that we get space. This is preventing us from having to do a crazy amount of interproximal reduction or reshaping in the lower anterior. We're resolving crowding the way that we would with braces, which is posterior buccal development. So here's what she looks like at the end of phase 1. Okay, 6 months. You can see there were about 24 trays. We were able to obtain our posterior maxillary development, maintain central incisor position. We did level the lower pretty well, but as you can see, things aren't ideal yet, right? We still have a little bit of buccal occlusion that we have to work on, and then we have a little bit more arch development. So all things are going well. This is what we expect out of the first phase. If we go ahead and we look at what we see clinically, we can see that our objectives were met. We're able to control the teeth, get most of the goals of our treatment accomplished in that first phase, knowing that phase 2 and phase 3 are going to be shorter. So 5 months with a month wait. So we're at 6 months with a month wait. We're at 7. That's phase 1. So now what are our instructions for phase 2? Well, this is where when the patient comes in, we're going to go ahead and do a little bit of enamel reshaping, maybe bond an edge if we have to, talk to her about what the goals are, ask her what she's looking for, how much energy she has left to complete the treatment. Usually in the first phase, they're like, hey, I love it. I'm excited. Let's keep going. Do what you do best. So in this case, what I would say is that we need a little bit more arch development, more buccal root torque in the posterior so that we can settle the occlusion. We also need to make sure that we intrude the lower incisors a little bit more, and then those canines need to be kind of tipped in a little bit. So if you look at what we tried to achieve, it's basically that. You can see that those canines are coming in, we're getting buccal root torque in the posterior, and we're settling the occlusion. That's kind of more of a settling protocol. Again, you need to have a lower level arch in order for anything to work out. With a significant curve of SPE, you're never going to be able to achieve a good overjet overbite relationship and a buccal occlusion. Okay, everything is kind of minor, and you can see we always tell our patients that phase 2 usually is much shorter than phase 1. So in this case, we've got about 12 active aligners. I always add 4 passive aligners. Those are just basically aligners that don't do anything so that the patient can change every week, stay on schedule, keep clean aligners while I'm waiting for the next set of aligners to come in, which typically takes about 2.5 to 3 weeks from scan. But again, with scheduling, sometimes that takes 3 or 4. And I don't want patient coming in with, dirty trays yelling at me that we're running behind or that we were delayed, because we want to make sure that we're always hitting our mark. So here she is at the end of phase 2. Again, I think that we accomplished those nicely. Now from here, I always tell patients that they get 3 rounds, and the third round is the tooth picking round. Once we're here, I'll give the patient a mirror. I'll say, look past the attachments. What do you see that you don't like? And it's a question not a lot of dental professionals like to ask their patients. But if she starts pointing at a lateral being a little higher or a tooth sticking out, let's say that upper left maxillary second bicuspid, it's easy for me to address that now because I have 1 more round that's included in her treatment. Again, we package this for a reason so the patients know what they're getting and what to expect, so that I don't get in this endless refinement phase, which I used to do. And again, in our courses, we teach people how to do this. 1, 2, 3, finished. And we do account for 1 additional 3+, but that's at a cost. So here we are at 10 months. We're very close. Now, what am I expecting? Well, I don't like the lower left lateral incisor. I do want to get those bicuspids tipped in. You can see that upper right is it's sticking out. So I put a incisal bevel detachment. Why did I put an incisal bevel detachment? Because I want a line of force acting on the flat spot of that attachment, which is going to help with the buccal root torque and lingual tipping. Again, it's a force diagram that's pure. It's hard to argue. So as long as the tray is tracking and fitting, that works really, really nicely. Again, we're settling that occlusion, rotating those lower canines, and just doing the small details. Now, one last thing that is in our third phase protocol is to tighten all contacts. One of the things that you have to have is something called zero collision contact protocol. That means that the aligner company will break everything apart by about 0.1 millimeter as they're moving teeth. But you have to remember to tell them to close that back up. Otherwise, you end up with patients at the end of treatment that say that their flossing contacts are light, they're getting food stuck. So in our third phase, we say close all contacts, do not follow a zero collision protocol. And the reason we don't is that most of the time, the teeth are already well aligned. We're just trying to do some small little details. Again, these are all things that we talk about in our course. So here she is at the end of phase 3. Again, now, the patients start to lose their motivation at the end of phase 2 because they don't see the fireworks. They see all the major stuff happening in phase 1. Then they're excited about phase 2 because they're like, well, I can't wait to see what else happens. But, we all know that most of the work was done in the first phase. So here she is at the end of treatment. Okay, you can see that things are looking really, really nice. Occlusion's good. She's going to be retained with, Essex, upper and lower Essex. And in this particular case, we decided to use a lower fixed retainer because she kind of admitted that she was a little bit less ideal with her wear of her aligners. She was worried about retention. So we said, look, the most important retention is your overlay Essex retainers. But at the end of the day, we can put in a fixed retainer as well. Good arch development, lower buccal uprighting. You can see that really her smile developed nicely. And look, I'll admit, I wish I could have developed it even more. But when you look at the lower arch sometimes dictates how much width you can get in the upper. You can't just indiscriminately widen the upper arch because the lower teeth have to fit. And if the lower teeth are uprighted ideally and they're hitting the outside of the mandibular ramal cortical plate, you don't have a lot of room to push those any further. So in this case, we kind of just left it here. She was super happy. And, again, everything kind of worked out beautifully. So not far off track. When you do cases in 3 phases, very distinctly, it's usually 7 appointments. We can do this in 5 if we're using Smart STL, which is a way that we can partner with our monitoring companies to take the refinement scans for us. But anyway, 7 trays, patient's happy. It's great. So, again, we're going to kind of intermix aligner cases with the stuff here at the Ultimate Orthodontic Academy. If you like this, definitely check us out. We're going to be posting more cases. We do have an aligner course coming up. That's going to be posted, which is awesome. It's 11 hours of content that is basically 20 years of me doing aligners, understanding biomechanics, cellular biology, attachment design, tooth movement. It's not just protocol based. It's actually education based. So if you like it, check us out, and more to come. Take care. Bye-bye.